Thank you, Dr. Bushra, for your kind introduction. Good evening to you all. I bring my warm greetings from this beautiful city of Abu Dhabi. And of course, when you visit Dubai, you should try and visit Abu Dhabi too. Am I visible? Am I audible?
Yes, doctor.
Okay. Dr. Saurabh has nicely set in the stage for me to talk about the pneumococcal vaccinations. As a physician, I always believe that medicine is an imperfect science without understanding the history of medicine. And Dr. Saurabh made it so well with his paintings that what has gone through the sufferings before the invention of these vaccinations. So without much of ado, I will try to cover about the pneumococcal disease and the pneumococcal vaccination. He has covered most of this history. So the pneumococcal disease history started off in 1881, where the Pasteur first identified the pneumococcus. And then subsequently, the gram stain came in 1884 that led to a concrete description of this Streptococcus pneumoniae. And the first hexavalent vaccine was launched in US in 1946. Then it became popular, and then somewhere with the introduction of the antibiotics, the popularity of the vaccinations went down. And then somewhere again in mid 70s, the conjugation concept came in, which led to the introduction of the conjugated vaccines, which led to a dramatic decrease in the pneumococcal disease. And then led to introduction of these vaccines in the vaccination schedule. So today I'm going to talk briefly, touch base about the pneumococcus and its the disease it causes. I will talk about polysaccharide and conjugate vaccines and schedule of the PCV vaccines. Of course, briefly, I will also touch base on efficacy and safety. As we all know from our medical school days, pneumococcus is a gram-positive bacteria, and there are almost 19 known serotypes, and most of these serotypes is due to the polysaccharide base. And that is important for its virulence factor. And each of the serotype is responsible for virulency and also the protective antibody titers that develops after the vaccination. So why do we worry about pneumococcus? Pneumococcus causes invasive pneumococcal disease, especially the meningitis, pneumonia, and sepsis. It is also known to cause otitis media and sinusitis. It can develop disease in any part of the body, let it be joints, let it be peritonitis, let it be myocarditis, let it be soft tissue infection, but mostly we worry about invasive pneumococcal disease. What is also known that influenza predisposes to pneumococcal infection, and if you treat and get a good herd immunity against pneumococcal diseases through vaccination, you can perhaps reduce the complications of influenza, the vice versa. As Dr. Saurabh was talking about, unlike the peak of the meningococcus, which happens in early adult, in childhood and adolescent, the pneumococcal has got a slightly different preponderance, where it affects predominantly young children and elderly population. So somehow in between the adolescent, they don't experience much of a pneumococcal disease. And it is a significant cause of invasive pneumococcal disease, especially in immunocompromised patients, especially like what Dr. Saurabh spoke about, like a splenectomy, chemotherapy patients, patients who have got HIV, immunodeficiencies, and also in immunocompetent patients who have got a barrier leaks. When I say barrier leaks, means the people who have got cochlear implants in those kind of a situation. So what does this pneumococcal do? It just harbors in our nasopharyngeal mucosa. It may then become an invasive disease and start getting into the bloodstream and causes invasive pneumococcal disease. Or sometimes it can just act as a carrier there, and then it can keep transmitting to other people, who, especially the susceptible host. It is known that most of the transmission occurs during the winter and early springs. And we really don't know about the communicability, but we think that it is mostly due to respiratory secretions. So what is important about the pneumococcus, as I told you in my earlier slide, the polysaccharide moiety is one of the important cause for the virulency. And although there are 90 varieties, serotypes of pneumococcus, thankfully 80% of the disease is caused by 20 types of serotypes. And around 75% of this invasive pneumococcal disease are caused by 13 serotypes. And this is where we are trying to target through the vaccinations. So although there are 90 serotypes, the majority are caused by at least 13 serotypes. And that is where the vaccine industry works on and try to cover these serotypes so that we can prevent the invasive pneumococcal disease. It is one of the #1 cause of mortality, especially under 5 years of age. And majority of the IPDs, that is meningitis and invasive pneumococcal disease, occur in children under 2 years of age. And just like the meningococcals, it does have a very high fatality to the tune of 20% for septicemia patients and 50% for meningitis. So the 20 serotypes I'm talking to you about, these are the type of common serotypes which are responsible for invasive pneumococcal disease. So if you look briefly into it, before the introduction of PCV13, when there were PCV7 vaccinations, you could see the type of the pneumococcal strains that were causing invasive pneumococcal disease. The predominant one were the 1 and 7F, which were very, very invasive. And then subsequently 19A, 6A, 6B, 19F, and 23F were less invasive. So see what happens when you start, when the PCV13 was introduced, you can see that the drastic drift in the kind of the serotypes which was causing the invasive pneumococcal disease. So the point I want to bring here is that focusing on certain kind of invasive pneumococcal strains and vaccinating them against them and involving them in the vaccination does have a big impact in the reduction in the burden of the disease. This Dr. Saurabh has already spoken to. It has gone through a long history from 14-valent polysaccharide to 23-valent to 7-valent to 10 and 13-valent. So why we have kept on adding is because, for example, it's when 7-valent polysaccharide conjugated vaccine was introduced, although it dramatically reduced the incidence of invasive pneumococcal disease, it was noted that certain other strains, especially 3, 19, 6, were responsible for invasive disease. Hence, there was a big dire need to incorporate these strains into the vaccination schedule. Hence, this vaccination kept on expanding. So when we talk about the vaccination, so we have to think about 3 or 4 important things. One is any vaccine that we have to give has to be highly immunogenic. That means that it has to protect against the disease by substantially mounting immunogenic response. It should cover most of the strains which causes invasive disease. Of course, the most important thing, it should be safe. And any vaccine should demonstrate effectiveness. When I say effectiveness means that it should also protect an individuals which do not take vaccine, who are unvaccinated, through herd immunity. So let's see, what is this polysaccharide vaccine? What is this conjugated vaccines? You always get confused as a clinician. What is this polysaccharide vaccine? What is this conjugated vaccine? If you look into the left side of my side, a polysaccharide antigen is just a protein. This protein, when it injected into the body, it carried by the dendritic cells into the lymph nodes, where just it stimulates the B cells. Somehow the T cells does not get stimulated when we inject a polysaccharide antigen. When you try to attach this polysaccharide antigen to a carrier protein, then it is a completely different ballgame. And this is the beauty of the vaccination. And that is when that is how the vaccination is progressing, where we want to attach more carrier proteins into any of the antigenic strains of the bacteria, in which by doing so, where we then stimulate the T cells. When we stimulate the T cells, then the response to the vaccination is completely different. Then it goes into the germinal center of the lymph node. It causes maturation. It goes through a maturation in the lymph node, which leads to a long-term immunity, that is affinity, avidity, creation of memory cells, and long-lasting immunity. So this is the basic difference between a polysaccharide antigen and a polysaccharide antigen which is being conjugated with the carrier protein. So that lands us to a difference between what is the difference between a PCV13 and a polysaccharide vaccine. So PCV13 means it has got 13 strains, PCV10 means it has got 10 strains, 23 means it has got 23 strains, serotypes. So target population, PCV13 can be given to healthy children and also can be high-risk children, which I will come in my subsequent slides. But PPV23, that is a polysaccharide vaccine, is designed purely for at-risk population. Polysaccharide vaccine cannot be given under 2 years of age because B cells are not high in number, and the response is suboptimal. Hence, these polysaccharide vaccines can be given only after 2 years of age. And as I discussed in my last slide, when we give a polysaccharide vaccine, it only stimulates the B cells. So hence, there is no long-term immunity, unlike any conjugated vaccine. And polysaccharide vaccine does not reduce the nasopharyngeal carriage. So these are the most important things one need to understand and clarify, have a clarity in their mind when we are talking about the pneumococcal vaccinations. So what are the strains of the serotypes of pneumococcal vaccinations we have? We had a PCV7, but nowadays we don't have PCV7 because as we have identified that other serotypes were causing disease, then the vaccine companies started expanding the introduction of few more serotypes so that there is an adequate protection against invasive pneumococcal disease. So for example, if you look into the PCV13, in addition to whatever the strains that is available in PCV10, it has got an additional serotypes against 3, 6A, and 19A. So this is something you may have to know as a clinician. 3, 6, and 19A have got their own virulency factors. For example, 3 is noted to cause necrotizing pneumococcal pneumonia. 6A is a type of virulency, can cause resistance to penicillin. And 19A is becoming increasingly resistant to antibiotics. So these are the focus where we are talking about in addition to the PCV10. But however, on the other side, the argument lies that the serotypes that are present in PCV10 may protect against these serotypes, especially 3, 6, and 19A through a cross-reactivity. That is their side of the argument. The new vaccination that we are all looking forward is PCV15, that is in the developmental stage, where it includes other serotypes, especially 22F and 33F. So this is something we need to know. And these are the kind of serotypes basically causes around 80% of the invasive pneumococcal disease. And by giving these serotypes in the vaccination, we tend to protect majority of the invasive pneumococcal disease, pneumonia, and other things. So let's look into the evidence whether there really does this kind of a protection, which is expected to do from them. So polysaccharide vaccine is conjugated to a non-toxic diphtheroid toxin, but in PCV10, it is conjugated to the non-typable Hib vaccine. So these are the difference because the carrier protein between the 13 vaccine and PCV10 vaccine are different. So let's look into the data, what has happened since the introduction of the PCV13, PCV7. So if you look into the 2005 and 2006, when PCV was introduced, there was a drastic decrease in the incidence of invasive pneumococcal disease. This is in the blue line. But as you notice, it didn't reach the baseline. because some of these invasive pneumococcal disease were caused by other serotypes which was not there in the PCV7. As a result, then what happened is PCV13 was, PCV10 and PCV13 came in with extended serotypes. So then you can look what happened since the introduction of PCV13. There furthermore decline in the invasive pneumococcal strains. So if you look into the protection of the PCV13, you can see there was all the strains, the serotypes that were involved in the PCV13 brought the disease right down and then continued to maintain. So now most of the invasive pneumococcal disease, as we can see, mostly occurs due to the non-serotypes, non-vaccine serotype. This is the kind of the disease that is floating on around, but not, there is no peaks. So similar findings in the paper from US, same reduction in the invasive pneumococcal disease with introduction of PCV13. There were further decrease in the incidence of invasive pneumococcal disease. So how much there is a reduction? You have to classify. So there is almost to the tune of 89% reduction of the invasive pneumococcal disease in the age under 5 years of age since the introduction of the pneumococcal vaccination, especially PCV13. And this is a drastic, this is one of the major achievement when it comes to the medical science. And if you look into and it is not only protects the children under 5 years of age. If you look into the children between 5 to 17 years, again, there is a reduction to the tune of 68% in the invasive pneumococcal disease between the children of 5 to 17 years. So this is about the different kinds of serotypes reduction. You can, where the pneumococcal 13 vaccination is given. So you can see in UK, there is a 91% reduction in 19A, 68% reduction in serotype 3, and so on. So what about individual serotypes? See, now what you have learned is that now that we expanded the serotypes in the vaccination, as all the serotypes, the expanded serotypes doing the justice, that means that what is the efficacy of these kind of serotypes? So PCV13, in addition, it covers majority of 90% of the strains. That is, it is found to be effective in 90% of the strains that is covered in PCV7. Plus, in addition, it covers the additional strains, especially 3, 6, and 19A. So what is the efficacy? It does have a good amount of protection, especially to the tune of 98% in especially 6A, 67% in 19A. One of the interesting thing about these pneumococcal vaccinations is that somehow, for some reasons, the serotype 3 has never produced that optimal immune response. And this has been replicated in many studies in different countries. It does have produces a good effective immunity against 6A and 19A. And however, for the 3A, it does not have that kind of an efficacy. So same thing with the Italy. So you can see 90% reduction in the type 1 serotype, 100% reduction in the 19A, and 100% reduction in the 7F, but no much of a difference in especially the type 3 serotypes. This is the same thing in US. What about otitis media? Yes, there is a reduction in the incidence of otitis media since the introduction of pneumococcal vaccination, but not 100%. So initially, when the PCV7 was introduced, the pneumococcal incidence of otitis media reduced by 21%, and subsequently, you expanding the serotypes further reduced by the incidence of AOM by 18.5%. This is the same thing with the different strains which are causing otitis media. So you can see 19A, 6A, almost it has reduced by significant amount to the tune of 90 to 100%. But even again in serotype 3, there is no much difference. So what is the consideration we need to think about when we are giving vaccination, especially pneumococcal vaccination? The three kinds of a situation. One is a primary immunizations, which is a part of the national immunization program. And the second one is a catch-up vaccination. And third one is a immunization in special circumstances. So primary vaccination schedule, if you look into it, there are different kinds of schedule practiced all over the world, and it is very dynamic. It keeps changing. For example, if you look into it in UAE, before 2019, we were doing a 3P plus 1, 3 primary plus 1 booster. From last year, we are doing a 3P plus 0 booster. In some countries, they do 2 primary plus 1 booster. So as you can see, there is so much of variations. And this is all based on the epidemiological data, the seroprevalence, the immunity that it provides. So, and then again, it can change. So I will show you what is the changes, how it can change, because some countries have started with somewhere, let's say, for example, a 3P plus 0, and then they went back to 2P plus 1 because there was a breakthrough infection. And there is, especially in children 7 to 11 months, 12 to 3 months, there is a different vaccination schedule. Especially between 7 to 11 months, you need 2 primary plus 1 booster. More than 1 year, between 2 years, you need 2 primary doses. And then more than 2 years, you just need 1 primary doses. And the same thing in a different fashion for PCV10 and PCV7. So what has happened? So I was telling you the dynamicity about the vaccination schedule. So this is the data from Belgium. So what they did is they were having PCV13, and then again 2011 they changed to PCV. Then 2015 they changed to PCV10. So then what happened is then there was an increase in the incidence of invasive pneumococcal disease. So they reverted back to PCV13. So this is all the changes that occurs based on the epidemiological prevalence and the incidence of pneumococcal disease. So what happened in Australia? So Australia, what they were doing is just like UAE, they were giving a 3 plus 1 schedule. And then subsequently they changed to 3 plus 0 schedule. And then they felt that there was increase in the incidence of pneumococcal disease. So they changed that they felt that there was a need for the booster because of the waning immunity, which had led to invasive pneumococcal disease. So went back to 2 plus 1. So this is what I meant to say. There is no schedule that is fixed. Each country has got its own immunization schedule, the way they immunize it, especially the pneumococcal. This is one vaccination. It keeps varying. So one has to follow what is locally, according to what the local country guidelines and national immunization program recommends. So this is another special situation. So pneumococcal vaccination is also given for children with immunocompromised state or children who are immunocompetent but prone to invasive disease, especially when we talk about these are the immunocompetent children who are prone to invasive disease. For example, a children with chronic heart disease, chronic lung disease, diabetes mellitus, who has got cerebrospinal fluid leaks, cochlear implants. This group of children will require polysaccharide vaccine, that is a PPSC23 vaccine, in addition to the pneumococcal conjugated vaccine. Again, just like Dr. Saurabh was speaking, the children with asplenia, children who has got HIV, renal disease, who are on immunosuppressive medications, who have got congenital immunodeficiency, will all require a polysaccharide vaccination in addition to the pneumococcal vaccine, conjugated pneumococcal vaccine. So the third group is the catch-up immunization schedule. So what is this catch-up immunization schedule? This is the vaccination schedule for the children who have missed it. I am sorry about this busy slide, but I don't want you to, remember everything, memorize it. This is available in the Red Book. It is available in the CDC. So basically, you need to be aware that there is a particular catch-up protocol for the vaccination. Under 6 months, you do more or less 3P plus 1, what we discussed about, or 3P plus 0. Between 7 to 11 months, you at least aim for 2 primary and 1 booster. If they've, so you aim finally somebody that should get at least 2 primary plus 1 booster. If somebody who's more than 12 months, but under 2 years, you at least aim for 2P. At least 2 primary booster. So what is important is after 1 year of age, the minimum interval between the 2 vaccination doses should be at least 8 weeks. Under 6 months, you can still give 4 weeks, although we give it here at 6 weeks. So 4 weeks is still okay. But after 1 year, the minimum duration has to be 8 weeks. This is again, we are talking about children under 6 years of age who have received pneumococcal vaccination. But what is the recommendation schedule for PPSV? We are talking about immunocompromised patients. So for them who are between 2 years and above, they should at least, we should aim for them to have at least 4 doses of pneumococcal vaccination, and then they should receive 1 polysaccharide vaccine at least 8 weeks after the last dose. So this is all important. So the polysaccharide, the order of vaccination is always first a pneumococcal conjugated vaccine. Then once you have finished the series, you give a polysaccharide vaccine 8 weeks after the conjugated vaccine. So especially in an immunocompromised situation, they will need 2 booster doses, the 2 doses of polysaccharide vaccine, that is after 5 years after the initial primary dose. But however, immunocompetent patients, but who are at high risk, for example, like cochlear implant and cerebrospinal fluid leak, you don't have to give a booster of PPSV or the second dose of PPSV. 1 dose is enough. This is again 6 to 18 years of age, immunocompromised. They should at least receive 1 dose of PPSV 23 and the second dose 5 years after the first dose. In case this is a hypothetical situation, if they already received PPSV 23, you know, the order is always conjugated pneumococcal vaccine followed by the PPSV 23. In case if they have received polysaccharide vaccine, still you can give a pneumococcal conjugated vaccine 8 weeks after the polysaccharide vaccine. So routine revaccination of the polysaccharide vaccine is not recommended. Polysaccharide vaccine can be given only after 2 years of age, because if you give it under 2 years, it does not activate the T cells as we discussed earlier, and the immune response is suboptimal. Only the children with immunocompromised situations will require a revaccination after 5 years after the first dose. So what about the efficacy? It is not 100% foolproof, but it does have a significant impact in reduction of pneumococcal meningitis from 54% to 27%, reduction in the invasive pneumococcal disease from 20 to 27%, 27 to 50%. I want to pause here and think about ourselves. I think we are from the generation where we have seen so many pneumococcal pneumonias, pneumococcal meningitis in the past. Now you sit and have a think about how many pneumococcal meningitis and how many pneumococcal severe invasive pneumonias you have seen of late. And this is all thanks to these pneumococcal vaccinations and also due to herd immunity. What about the adverse reactions? Thankfully, the adverse reactions are very mild as compared to any other vaccinations. The predominant adverse reactions are either local reactions or mild systemic illnesses like fever or myalgias. It can cause sometimes sleep disturbances. There have been some reports about risk of febrile seizures when co-administered with influenza vaccination, but that does not stop you from giving the vaccination because the risk is very, very small. When you don't want to give, there are 2 contraindications. If they have a severe allergic reaction to the vaccine component, where especially you have given the previous vaccination and the child had a severe allergic reaction, then you don't give it. Moderate to severe acute illness, you wait and you postpone it. Mild illness, you can still give the pneumococcal vaccination. Co-administration, I don't dwell much here. Dr. Saurabh has already discussed that it cannot be co-administered with some kind of a meningococcal vaccinations, and that has to be 8 weeks gap. So this is what happening all over the globe. The blue is PCV13 vaccination used by many countries. Orange is where some people are using PCV10, and in between some countries are using PCV10 and PCV13. And this is the different kinds of a schedule. The orange one is a 2+1 schedule. The light gray one is 3+1 schedule. The less gray gray one is 3+0 schedule. So you can see the different kinds of a schedule that is being followed in different countries. It is purely based on their epidemiological data and also from the trend of invasive pneumococcal disease that they have monitored over the course of years since the introduction of the pneumococcal vaccine. This is again in the different countries. You can see some countries purely give PCV13, some countries give PCV10 and 13, some countries give a change from PCV10 to PCV13, some countries have moved back from 10 to 13. So this is purely the epidemiological data, and based on the epidemiological surveillance, the schedule keeps changing. Different countries have different perspective. The UK feels that PCV13 should be better because it offers better immunity. So does Canada, and so does India, and so does Hong Kong. However, the WHO position paper in 2019 said 10 and 13 have got a comparable immunity and impact on IPD, pneumonia, and nasopharyngeal carriage. So they don't differentiate. However, there are few considerations one need to think about when giving the pneumococcal vaccination. Your immune response in immunodeficiency in immunosuppressive state may not be optimal. It has to be given intramuscular, but if there is extraordinary conditions where you have an hemophilia, bleeding disorders, you can consider subcutaneously based on the risk benefit of the vaccination. It can cause apnea in especially extreme preterm babies. No data for use of pneumococcal vaccine in pregnant women. This is the area of research. We need to think about whether we need to increase further serotypes. As we know, PCV15 is in the stage of development. Think about whether PCV can be used in an epidemic outbreak scenario, like serotype 1, which causes epidemic outbreaks. PCV and antimicrobial use. Yes, there has been a significant decrease in the antimicrobial use because of the vaccination, because we don't prescribe as many antibiotics as we used to before for the Streptococcus pneumonia. In that way, it has helped. But more data is required to show its effectiveness. We need some more data to look if there is 1-dose schedule to 2-dose catch-up schedule in children more than 12 months of age. So summary, PCV vaccination are quite effective. They reduce the incidence of invasive pneumococcal disease to the tune of 80%, all types of serotypes by 58%. It has reduced the incidence of invasive pneumococcal disease from 95 per 100,000 to 9 per 100,000. That's a significant. So take-home message, routine pneumococcal vaccination is effective in preventing IPD and providing herd immunity. Children with recurrent IPD, despite vaccination, your antenna should be up, and think about immunodeficiency. You have to think about why these children, despite of vaccination, are getting the invasive pneumococcal disease. This is Edward Jenner, who is called the father of vaccination. Vaccinating against the smallpox. Without this man, we wouldn't have thought about the concept of vaccination. So in this era of a pandemic, I think the most important thing, and we all want to advise ourselves and also our patients and parents, is be wise and immunize. Thank you once again for your patient hearing, and happy to take any questions.